I'm Howard Silby. I'm 75 years old. I live here in the area. In the last 13 years, I've lost 7.5 organs to 6 surgeries all done here at the NIH. 2.5 years ago, I was diagnosed with prostate cancer. That's one of those 7.5 organs that I've lost. Knowing that my family history, my father dying of the disease, I've kind of been on the watch out for it. I've had a bunch of biopsies, a bunch of MRIs. Finally, 2.5 years ago, on about the 6th or 7th biopsy, and this special program that they're doing here with the high field strength MRI, the 3 Tesla machine, along with ultrasound and merging those images, they found a little spot, biopsy that, was positive.
And the whole point of this is to try to develop better ways of diagnosing prostate cancer earlier and more accurately. Eventually, to do away with surgery altogether and simply do minimally invasive techniques for treating it. So this is a multi-step process. That involves doing endorectal coil MRI scans. It comes out very similar to this. And when we look at it using the multi-parameters that we obtain with the MRI, we're able to assign probabilities based on the imaging that the man actually has a cancer and the risk that it's a high-grade or aggressive cancer. The 2 modalities that we use are the MRI and PET scan. We can begin to put together with PET scanning metabolic picture or a molecular picture of what's going on inside a cancer cell. So when you combine the functional kind of information, molecular information that we get with PET scanning, with the anatomic information that we get with MRI, that's a very powerful fusion of information. In fact, literally, we fuse the one image to the other image. The patient then goes to a separate room in the hospital where there's an ultrasound device, and we register this MRI information to the ultrasound so that the man then gets a biopsy of his prostate using ultrasound, which has the desirable features of being real-time and so that you can watch the progress of the needle very accurately. The imaging provides the roadmap for that. It tells the physician where to biopsy, what to biopsy, and so that's why it's critically important.
You know, if you go to your regular urologist and they do an ultrasound and they see something a little funny, ordinarily they shoot a bunch of needles in there. They're kind of going blind. They're just taking 8, 12, 10, 12 cores and boom, boom. They kind of stick in the area where they see it, but it's not specific. And the thing about the study here is they see specifically exactly where to go.
So the MRI and the PET scan adds a lot of information to what he knows. And so more accurate knowledge will make patients have better information, make better informed decisions about what kind of treatments they should have.
I mean, this is a really, really tough decision. What do you do? Because there are all these options, and there's no evidence that one is really better than the other. They laid out all the options for me. Nothing, do radiation, do surgery, and I thought about it and got a lot of consultations and a lot of thinking and talking over with my family and my wife and my kids and so forth. And I decided on the route of surgery. Because the radiation and the surgery both have the same side effects. You can still become incontinent, you can still lose your sexual function. Urinary function is as close to 100% as you can get. Sexual function, I'm 75, it's not so great, but it's satisfying. I'm happy, I'm not depressed, I'm not upset about it. It's enough. It's enough that I feel comfortable. And that's a small price to pay for knowing that I'm still alive.